Divisha Arthritis and Medical Center, Basveshwanagar, Bengaluru. I welcome you all on this Sunday. Thanks for attending this session. I call this as Rheumatology Secrets. The reason being, we are all in busy OPDs where time is the key essence, and our patients trust us and come to us so that we do justice to them. Getting things right in the quick span of time without wasting their money and improving their quality of life is the key to actually doing justice to those patients. I believe their trust in our doctors is actually the God. God is not visible to us, but the trust is visible to us. I often tell this to my staff. So, clinical secrets, I will keep this very simple. Most of this you already know, but putting it all together and explaining it, how to take it in an approach-based aspect is all about today's session. I've called this as part one because rheumatology is extensive, and in the current part, I've dealt with only 4 topics, which I'll come to shortly. I've previously worked in Manipal Hospital, Old Airport Road, as consultant rheumatologist for nearly 8 years from 2014. And prior to that, I was in Queen Elizabeth Hospital where I did my consultant job as locum. I did all my rheumatology and internal medicine training in West Midlands Deanery in Birmingham, UK, and MBBS from Bangalore Medical College. After my return from the UK, I worked in Manipal, and soon I realized that rheumatology is a field where patients feel more comfortable in a clinic-based setup rather than in a hospital. So, with blessings from Lord Vishnu and my father, I opened this Divisha Arthritis and Medical Center, which caters to autoimmune rheumatic diseases patients in Basveshwanagar, Bangalore. And we see nearly 60 to 70 patients a day, and been doing so since 2017, 14th of December, when we opened it. Till Jan 2022, we were only part-time from evening 3 o'clock. And from Jan last year, we're full-time from morning 9 o'clock to evening 7 o'clock. So I've been fortunate enough to work with some of the well-known professors in the field of rheumatology, and I've had published in national and international rheumatology journals. Just in the recent past, I was assistant editor for Indian Journal of Rheumatology, and I'm currently an active examiner for the Royal College of Physicians for MRCP exam, which is the clinical exam, exit exam for general medicine in Manipal Hospital, Bangalore Center. I'm also grateful to Karnataka Rheumatology Association for recognizing me as the convener for educational meetings for rheumatologists at Bangalore, where we discuss cases among the rheumatologists and we discuss esoteric topics. We do that once in 45 days. So with that background, I shall move on to the core part of this talk. Rheumatology is all about history taking, as we know that it has varied manifestations and it is multi-system, and predominantly in day in and day out, we always check whether the patient has inflammatory or mechanical. In the same patient, we might be having both inflammatory and mechanical features. So I tell this often to my junior doctors and co-colleagues who work with me that at every point in time, every symptom patient tells you, always think whether this is inflammatory or mechanical. Inflammatory predominantly is early morning pain, pain worse in the later half of the night or first half of the morning, pain worse with rest, better with activity, pain better with NSAIDs. That is predominantly inflammatory. Whereas mechanical is pain worse with rest, pain worse with activity, pain better with rest, and it's more of degenerative in nature. The same patient with arthritis can have both, and we need to treat both as different. Giving inflammatory treatment to a mechanical patient would be unwarranted and would alter the risk benefit ratio or profile. Vice versa, giving mechanical treatment or symptomatic treatment to an inflammatory patient would lead to poor quality of life and not improvement of disease activity. So we often recognize what is the pattern of joint involvement, whether it is single joint, as we see in osteoarthritis or gout, whether it's less than 4 joints or more than 4 joints, as we see in oligoarticular arthritis or seronegative arthritis, or more than 4 joints, whether it's polyarticular like rheumatoid arthritis or connective tissue disease. Very important to recognize extraarticular symptoms such as fever, weight loss, loss of appetite, malar rashes, that is rash on the cheeks, rash on sun-exposed areas, severe alopecia with no other cause identified, mouth ulcers, breathing difficulty, shortness of breath, pleurisy or pleuritic chest pain, fatigability, dry eyes and dry mouth, called as Zika symptoms, rashes such as psoriasis or purpuric or vasculitic rashes, low back pain, heel pain, Achilles tendon pain, and elbow pain, so on and so forth. All these point out to a disease, which I shall come to you shortly. Very importantly, we need to identify occupation, as most of the symptoms might be coming from the nature of lifestyle the patient is leading, whether he is sedentary, he or she, or whether he is physically active, whether he or she sits long time without break, more than 6 hours, as we call sitting is the new smoking and sugar is the new cigarette. And diet, whether patients are taking a lot of sugar, sweets, or red meat consumption. All these factors, as I tell my staff, is very important in rheumatology history taking. Hence, in our clinic, we have actually gathered all this in something called as a data information sheet. We give it to the patient at the patient waiting lounge. While they're sitting and waiting for us, they fill this form. And when our junior doctors records this on prescription before they see me, they can easily enter all this. So it makes sure that we were not missed out anything when they have actually identified the symptoms themselves. And they might tell it that we have ticked it and we have not touched upon. When I actually ask them at the end of consultation, is there anything else you want to talk to us? So that's the key thing about in terms of history taking. Whereas, teasing out whether it's inflammatory, non-inflammatory, organ involvement, and multitude of symptoms. Today, I shall be talking to you clinical secrets of rheumatoid arthritis, seronegative arthritis, connective tissue diseases, and vasculitis. So these are predominantly inflammatory conditions. Whereas in the next session, which I'll be announcing shortly, we'll focus on the non-inflammatory metabolic conditions, which is fibromyalgia or non-inflammatory soft tissue conditions, gout and hyperuricemia, osteoporosis and orphan diseases such as IgG4 disease and Dada syndrome, Vexus syndrome, which is all the new age onset of diseases we have found in rheumatology. Rheumatoid arthritis. This is the standard bread and butter of all doctors treating patients with pain, swelling, stiffness in the joints. So it's usually bilaterally affecting on both sides of the body. It is symmetrical, that is on both sides of the body, and usually more than 4 joints. As you see here, the red ones are very common. So the small joints of the hands, that is the MCPs and PIP joints. Uncommon are the DIP joints in rheumatoid. And these are very common, the red ones, and also the feet and the MTP joints. Other common ones are wrist joints, elbow joints, shoulder joints, whereas AC joints and acromioclavicular and also sternoclavicular joints are less common in rheumatoid. Hip joints are very less common, and knee joints are common. Again, feet and ankle are very common. If you see spine is spared, if any rheumatoid patient comes and tells me I have back pain, it's usually, unless and until proven otherwise, a mechanical back pain. And the history would actually coincide with that. So in a rheumatoid patient, they are the patients who usually come early in the morning with pain, stiffness, swelling in the joints, which is worse in the mornings and better with activity. And swelling may be there and may not be there. In the early the days of the disease, within 3 months, majority of patients do not have swelling. It might come and go. But all of them usually have pain and stiffness, which is worse in the mornings and better with activity and worse with rest. As I told in this cartoon, it does not affect spine and hips primarily. It could be a secondary, like a degenerative joint, which can happen in these patients with early onset of hip and knee OA, especially if untreated. So usually diagnosed by rheumatoid factor and inappropriately usually called as RA factor, but it should be called as RF, and which is appropriately done by nephelometry method. If done by latex agglutination, it is actually a qualitative test, either positive or negative. It should be done by nephelometry, and it is a quantitative one. And test consistently above 40 means the diagnosis of rheumatoid is made. Citrulinated cyclical peptide, or anti-CCP or ACPA, is basically more positive predictive value for rheumatoid, worse prognosis for rheumatoid. Just tells us that if we do not treat rheumatoid or untreated or prematurely stop the treatment, these are the patients which might go for erosions or bad prognosis. So anti-CCP, I have many patients who have rheumatoid factor negative but anti-CCP positive. And vice versa, I have many patients who have anti-CCP positive but rheumatoid factor negative. So the European Rheumatology of Rheumatism actually says it's either one of them, both having above 40 or twice above 40, that is above 80, is highly significant of rheumatoid. It's only for diagnosis, my friends. It has no value for response to treatment. I often have patients who come and say, sir, you have told me that my symptoms are fully normal, but my rheumatoid factor level is still 180. I tell them this is a wrong way of checking how your rheumatoid is. Rheumatoid factor and CCP test is only useful for diagnosis. It's got no value to actually check how the treatment is working or if the disease is still there or not. Even if I've treated the patients by 1.5 years and 2 years and they're continuously in remission and have tapered the treatment and stopped the treatment, rheumatoid factor and CCP will be high. So I often tell them, don't check it, don't waste your money. And that's how it should be. So these are the little secrets I want to tell you about rheumatoid arthritis in terms of diagnosis, pattern recognition based on the joint involvement, symmetry, which joints are commonly involved, nature of symptoms, whether morning or late evening or night, and what is the value of these tests. And majority have high ESR and CRP, but in the early stage of the disease, most patients can have a normal ESR and CRP test. So that does not rule out. That's what I've told here, that a normal ESR and CRP does not exclude the disease. That's what I tell my team as well. It only means that the disease is not very severe. And if you're treating the patient, it only means that the disease is serological remission. It is called as serological remission. Clinical remission is when you examine and they have no stiffness, no pain, no swelling in the joints. And ESR being normal, they're called as clinical remission and serological remission. It just means that you can taper the treatment, or if it is at the lowest dose beyond 6 months, you can attempt to stop the treatment provided it's the right climate, provided patient is regularly physically active, provided the patient is actually eating healthy diet, and tell the patient that you may stop, but the disease may come back. If it comes back, you need to approach me back. So this is what I wanted to tell you about the serology. Now, symptoms of joint pain, stiffness and swelling, morning stiffness, fatigue, feverishness in the evening, which is all early symptoms. If it's more than 6 weeks, that is 45 days, we wait until then for DMARDs, my friends. So then we need treatment with disease modifying anti-rheumatic drug therapy called as DMARDs, which is well known to all doctors now. And with either rheumatoid factor or CCP or ESR or CRP being normal or elevated. So if all of these are normal and the patient has symptoms of all this, then you have to treat even after 45 days. I repeat my statement. If rheumatoid factor, CCP test, ESR, CRP, all are normal. But if your patient in front of you has joint pain, swelling, stiffness, which is worse in the mornings, worse with rest, better with activity, tiredness, early morning tiredness, and mild evening feverishness, if it is more than 45 days, my friends, even with the serology being normal, they need treatment. Otherwise, their quality of life is not better. This is the take home you have to take from this slide. All of us know how to treat it if things are abnormal. But if things are all normal, that is why I see in my referrals from other my colleagues, so I'm very grateful to actually for patient benefit, they refer to me. So what are the standard disease modifying anti-rheumatic drug therapy we use? Methotrexate, which is short form of MTX, leflunomide, short form of LEF, SSZ is sulfasalazine or salazopyrin, HCQ is hydroxychloroquine, we all aware of that, and tacrolimus is often also used. Tacrolimus is not so much in recognition, but very useful at a 1 milligram twice a day dose. That's the max we use in rheumatoid. Especially tacrolimus is useful in pregnancy patients where this is safe in pregnancy as it does not harm the baby. So it's also useful for refractory patients who have become resistant to methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. But better used by under the supervision of a rheumatologist. It doesn't need any drug monitoring as in transplant patients. You have to tell patients that this is not given for any kidney problem. It does not cause that, but it is given for arthritis. It is not evidence. It is evidence-based, but not in guidelines. So it is out of guidelines if we use it. Hence, better used by a rheumatologist. But the standard drugs, methotrexate is useful in most patients. That is the anchor drug in 100% of rheumatoid patients. And it has got efficacy in more than 70 to 80% of patients on its own. But these days, combination treatment we combine with hydroxychloroquine or leflunomide or sulfasalazine. Sulfasalazine, the main problem is causing anaphylactic or drug-induced urticarial rashes. So we warn patients about that, and we actually tell them that, in fact, I give them 500 mg BD dose for the first 1 month and then escalate after my review. Even with 500 mg BD dose, I've had a couple of cases where they have severe anaphylaxis, severe urticaria, like Steven Johnson kind of picture, and they had to be admitted to the hospital. Hydroxychloroquine needs annual retinal toxicity review by ophthalmologist, and patients have to be mentioned that to tell ophthalmologist that they are on this drug. If less than 1 year, I don't do it. Baseline generally has to be done, but not mandatory. Leflunomide, the only issue is it's got teratogenicity. Hence, women who have not completed family or who are wanting more kids, I don't give them because it stays in the bone for 2 years. So if patient, even if you stop it today and give a drug holiday for 3 months, as we do in methotrexate, leflunomide stays in the bone for 2 years. And if they have to attempt pregnancy, then they have to have cholestyramine washout. But sulfasalazine is safe in pregnancy, hydroxychloroquine safe in pregnancy, tacrolimus safe in pregnancy, methotrexate has to be withdrawn 3 months before they plan for pregnancy and they have to be in contraception. These are all actually printed in my prescription, and we often tell it to the patients as well. The onset of action of tablets is usually 1 month, but I tell the patient that peak onset is by 3 months only. So patients have to be patient and you have to tell them that it's a gradual working medicine and none of these are steroids. They have to be, patient to wait for the response. I often tell this that it is like climbing a hill. We take 3 months to go up, reach the peak level of the tablets when their symptoms are under control. Then 3 to 6 months we stabilize and maintain their symptoms. And 6 months to 9 months to 1 year, we reduce the dose. So we take this, what we call as parabola or curve effect, to actually come down the treatment. Sudden stoppage of treatment will actually cause relapse of symptoms. So I see them at first month, then I gradually call them at third month, and then I dose escalate, and monitoring of blood tests, that is CBC, SGPT, creatinine is mandatory. These are minimum ones which has to be done 1 to 3 monthly. Now, lactation safe and pregnancy safe, I've already told you, sulfasalazine has to be given folic acid in pregnancy to prevent neural tube defects in the first 3 months. Hydroxychloroquine is safe in pregnancy and breastfeeding. Only thing is, when patients go to sunlight, they might develop black pigmentation and they might turn into bronze or a slate gray pigmentation. So just warn them about that. Young unmarried girls, you don't want to disfigure them. Tacrolimus, as I said, no need of drug monitoring. 1 mg morning and night works beautifully well, has got very short onset of action. And I give them about 3 to 6 months and taper. You can taper to 0.5 BD and then 0.5 OD and gradually stop. So combination treatments are generally effective than single agents, as I just told you. And slow taper, you can attempt it after being 6 months of remission. But if they are any way flaring up, then of course you'll have to stop it on that particular dose at which they are flaring. In terms of extra-articular manifestations, so you have to use lubricating drops for dry eyes. Pilocarpine tablets these days are very much available for dry eyes and dry mouth. 5 mg OD can be used. They are very, very good. And lubricating eye drops such as Refresh eye drops or Tear Fresh can be used, including Lacrygel ointment if it is severe at night. And if they have episcleritis due to rheumatoid, then of course NSAIDs have to be used. If scleritis is there, then they need potent immunosuppression such as cyclophosphamide, steroids, or mycophenolate, as other tablets won't work. Mononeuritis multiplex, I have a couple of cases of rheumatoid with third nerve palsy, where they come with ptosis and squint, and you will have to use steroids in tapering dose, starting with 0.5 to 0.75 milligram per kilogram, depending on their body weight, and institute maintenance of mycophenolate or tacrolimus or azathioprine. If inadequate response, then cyclophosphamide or rituximab. If cyclophosphamide cannot be used due to fertility issues, then you can combine mycophenolate and tacrolimus as a combination. In rheumatoid ILD, we know that interstitial lung disease, it causes something called as usual interstitial pneumonia or UIP, which is a fibrotic lung disease. And for preventing inflammation in this lung, we use mycophenolate mofetil. Antifibrotics such as nintedanib or pirfenidone can be used as well in combination. And rituximab can be used, but response is quite less if it is FVC is less than 40%. So if it is 40 to 60% better response, if you use early, better response if it is interstitial lung disease. Rheumatoid vasculitis causing any of the mononeuritis multiplex or vasculitic skin rashes or gangrene, then again, potent immunosuppression with mycophenolate mofetil, tacrolimus, and tofacitinib definitely can be used along with rituximab, which is a B-cell blocker. Other extraarticular manifestations like peripheral neuropathy, cervical myelopathy these days are very common due to atlantoaxial dislocation. Interstitial lung disease I've already alluded to. Serositis such as pleural effusion, you have to treat it as in any aggressive rheumatoid. Rheumatoid nodules or vasculitic rashes. Nodules can be used due to methotrexate usage. You might switch to other drug and the nodules become normal after that. Pericarditis or myocarditis, again, you will have to check whether this is a part of a rheumatoid disease. and if immunosuppression is indicated, you have to treat it. Otherwise, NSAIDs and colchicine are very useful, and cardiology involvement definitely is required. Hematological, such as neutropenia or feltis, you have to be careful about the drugs you usage, and make sure that anemia is treated well in rheumatoid patients. Vitamin B12 deficiency is checked, and peripheral smear is always looked at in such patients. These are the common extraarticular manifestations, friends, we see in rheumatoid. Now, if you come to in terms of what are the other treatment agents we use in rheumatoid, biologicals, but B DMARDs or TS, targeted synthetic DMARDs. So targeted synthetic DMARDs are not biologics. They're used before biologics or after biologics. They're called JAK inhibitors or Janus kinase inhibitors. These days are very popular among several of our colleagues because of the generics and their cheaper availability. But they have their own problems. You have to be careful and look for any tuberculosis history in the patient, and in such cases, avoid or screen for tuberculosis. Warn them about other fungal infections. I have very resistant tinea infections on tofacitinib. They can develop other serious infections or bacterial infections or pneumonia or herpes zoster. So you have to vaccinate them with flu and pneumonia vaccine and herpes vaccine. And in patients who are at liable or malignancy risk or long flight travel or recent surgeries, immobile, you have to be aware of deep vein thrombosis, pulmonary embolism, arterial thrombosis risk with tofacitinib. Also, with the recent oral surveillance data coming from US or US FDA, tofacitinib is better avoided above 65-year-old, especially with risk of serious infections, malignancies, ischemic heart disease, those with stents or medical management. However, if the disease activity is very high and you are using very high doses of steroids, then using it in short term after discussing with patient is not a bad idea, because you might actually reduce the steroid, make the patient mobile, and make them better mobility and reduce the risk of cardiovascular problems. So it can be used with the current methotrexate or alone. However, usage with biological DMARDs such as anti-TNF or anti-IL-6 or anti-B cell is not suggested. So it has to be used on its own. The initial approval was tofacitinib, which is approved for rheumatoid arthritis, psoriatic arthritis, inflammatory bowel disease. And then came baricitinib in 2018, which has got generic license after the COVID, which currently is licensed by DCGI for rheumatoid only. But tofacitinib has got DCGI license for RA, psoriatic arthritis, and inflammatory bowel disease. Upadacitinib has got great results. It's a selective JAK1 inhibitor, but still yet to come to India for DCGI approval. Trials are all completed. So it is currently very good for rheumatoid arthritis. Now, which are the pathways for biological DMARDs? So it is anti-tumor necrosis factor TNF alpha, which is in the IV form, introduced in 1998, called infliximab, given IV in our daycare unit. So we give it monthly for 4 months, and then after that on demand. These days, it is out of fashion for rheumatoid because of the generic JAKs if they fail the standard conventional DMARDs. Etanercept is a subcutaneous injection which is given weekly. I normally give it for 6 months and then taper depending on the patient response. So there are again generics in this, but safer in tuberculosis patients or TB risk, as the TB risk is very less. And what we call as drug resistance is very rare in etanercept compared to adalimumab. Adalimumab, various generics have been in place now. It is given as a 2-weekly injection. I use it for 6 months, following which I taper. So TB risk is slightly higher compared to the JAKs and also the etanercept, and better compared to infliximab. Infliximab TB risk is slightly higher. But other thing is drug resistance. If we use beyond 1 year, then patients lose response due to anti-adalimumab antibodies. Golimumab generics are not there, very expensive, given monthly ones, but works well. Again, anti-drug antibodies are seen in golimumab. Certolizumab is a pegylated anti-TNF, which is not there in India. Abatacept is a T-cell core-stimulating factor which inhibitor, which is initially was there in India and has been pulled out by BMS, which is the company. Rituximab, which is a B cell blocker available in generics, which is given as 2 doses, 1 gram, 15 days apart, intravenously in daycare unit. In our daycare, we give, which takes about 4 to 6 hours. Can be repeated in 6 monthly if required. I rarely do it, but has got great response in patients who have failed several. But I use it after anti-TNF failure, after JAK inhibitor failure, but first line in interstitial lung disease had its response very well. And also in cases of mononeuritis multiplex, or in case if ANA coexistent is there in rituximab. Tocilizumab is IL-6 blocker. So that is actually given as a subcutaneous injection these days in our daycare unit, and also given as an IV. And it's given both as a monthly IV or 2-weekly subcutaneous. Especially it's got used with rheumatoid arthritis with the overlap PMR, polymyalgia rheumatica, or GCA. Works very well. Available in generics as well, especially with IV form, and subcutaneous is still in the originator form. In this, the anti-TNF is safe in pregnancy and lactation, but B cell blocker and anti-IL-6 is not safe in pregnancy and lactation. So these are used for better quality of life improvement, patient selection, as I told, by organ involvement, severity, whether they are the main breadwinners of family and you have to treat them aggressively, if you have to use it early so that you have early control, younger onset of disease because it is severe, and also if it is aggressive disease for quick quality of life improvement. Usually taper after they are in remission, and you have to priorly screen for all infections, and as I told, avoid in ischemic heart disease and malignancy in JAK inhibitors. So rheumatoid took a while, although I assumed that I would be able to finish it in 15 minutes. But as you know, rheumatoid is the standard once we treat. Hence, I took long time. Apologies for that. Moving ahead quickly with seronegative arthritis, or collectively now called under umbrella term as SPA or spondyloarthritis. As you see, ankylosing spondylitis, which was traditionally called, is in the core part of the central. But all this, which has psoriatic arthritis with axial or spinal involvement or peripheral involvement, acute anterior uveitis with just HLA-B27 positive, reactive arthritis with either genitourinary or gastrointestinal infection followed by asymmetrical oligoarthritis also comes under this. Arthritis associated with inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, with axial or spinal involvement, and peripheral joint involvement with asymmetrical oligoarticular arthritis, that is on one side of the body and less than 4 joint involved, that also comes under this. Patients under 18 years of age with all these manifestations are called juvenile spondyloarthritis, especially if they have enthesial involvement, that is attachment sites of tendons onto the bones. And none of these if they are fitting into any of this, but they still have asymmetrical oligoarticular arthritis with spinal or axial involvement or hip involvement, asymmetrical involvement, they can be called as undifferentiated spondyloarthritis. So it can affect the eyes, as I told, it can cause anterior uveitis, it can cause peripheral arthritis such as knees, feet, and ankle, or dactylitis or Achilles tendinitis, or in case of lateral epicondylitis or plantar fasciitis, or spinal arthritis such as enthesial involvement, anterior longitudinal involvement, spinal pain, inflammatory back pain. Psoriatic disease can cause uveitis, peripheral arthritis such as dactylitis, asymmetrical oligoarthritis, and spinal involvement. IBD involvement, as I already told, and GI or GU infections followed by eye involvement such as conjunctivitis and urethritis. And finally, the undifferentiated variety. Now, this is the slide I've borrowed from ASAS, which is International Society for Spondyloarthritis, which does all the cutting edge research. They've come up with this criteria, especially useful for trials purposes. That is, if any patients having inflammatory back pain, pain in the lower part of the body or neck, which is worse in the mornings or second half of the night, better with activity, worse with rest, better with NSAIDs, and more than or equal to 3 months and less than 45 years of age. This need not be strict. I mean, I have many patients who are above 45 years also, and I have many patients who are less than 3 months also. But generally, this is what. And they have more than one of this called SPA features, that is inflammatory back pain, which I just alluded to, peripheral arthritis, which is asymmetrical oligoarticular arthritis, that is painful swollen joints on one side of the body at a time and less than 4 in involvement, and dactylitis, which is whole finger swelling like sausage finger or sausage toes, enthesitis such as heel pain, which is often called as calcaneal spurs, worse in the mornings, or Achilles tendonitis, family history of inflammatory arthritis of the back or ankylosing spondylitis, good response to painkillers or NSAIDs, current or past uveitis, current or past psoriasis, inflammatory bowel disease, current or past, HLA-B27 done by PCR technique, current or past, I mean, always it has to be there, it will never go. Flow cytometry has a lot of false negatives, so better to do under a PCR method, and elevated CRP. If greater than or equal to one of these is there, plus if sacroiliitis is there, either one side or both side, which is the joint connecting the hips and the spine, on X-ray or MRI. If early, then do an MRI. If late stage, you can see on X-ray, at least grade 2 to 3 bilateral. Then you can call it safely as spondyloarthritis. But if it is too early and X-ray is not showing or MRI is not showing, but you have HLA-B27 positive and more than 2 or equal to or 2 or more than 2 of these features, then it can be still called as spondyloarthritis. And you treat it accordingly, patients get better. So this is what you have to use it for your day-to-day diagnosis for your spondyloarthritis patients or patients who come with any of these symptoms. As you can see, it is varied in symptoms. It's not easy. You have to be very careful in your history taking in your examination. If you miss in any of these features, you're wrongly labeling them as seronegative RA. Seronegative RA and seronegative arthritis are both different, my friends. Seronegative RA is RA type of distribution with no RA or rheumatoid factor or CCP or normal ESR, that is bilateral hands, bilateral feet, but no serology. That is seronegative RA. This is seronegative arthritis. These are totally different pathology. You need to identify this. That is why I'm slowing down here and telling you it is very, very important that you need to identify this. Without identifying this correctly, then you are liable to make mistakes in diagnosis. Next, if you look at the area of involvement in these joints, the enthesitis can occur in any of sternoclavicular joints, costosternal joints, costovertebral joints. It can occur, anterior superior iliac spine, posterior superior iliac spine, iliac crest, and insertion of Achilles tendons, plantar fascia. These are all enthesial attachment sites. Friends, it is important you recognize that none of these are visible swelling. Patients tell you I have swelling there, I have pain there, sir. I have pain worse in the mornings. You must make an attempt to actually go to these areas and check. Very importantly, strip the patient and check. Then only you will actually able to identify the pattern of recognition of these joints. Otherwise, you will wrongly label them as fibromyalgia or wrongly tell it's a mechanical pain or seronegative RA, which is totally different disease compared to this. And you have inflammation swelling such as dactylitis, redness, or you can see stretched shiny skin, and warmth you can see, and pain. And in all of these, dactylitis, psoriasis is main key factor involved. Uveitis, either it can be an anterior uveitis affected in the anterior chamber, or intermediate if it is in the vitreous, and posterior if it is in the choroid. Inflammation of all, if it's posterior pan uveitis, in all parts of uvea, which includes iris, ciliary body, and choroid. So it can happen in all parts of this if it is severe, but most commonly in the anterior uveitis, in this spondyloarthritis category. Moving on, patients with spondyloarthritis, that is non-radiographic, is where X-ray is normal but MRI is shown. That comes under the category of non-radiographic spinal spondyloarthritis. And ankylosing spondylitis, they have common features, as I told you, uveitis, which is painful swollen red eye, which can be either one eye or both eye, and patients rush to the eye doctors to get steroid drops. You have to ask them in your history, either current or past or family history. And enthesitis, which I just showed the points of where all the pain is in terms of attachment of tendons or ligaments to the bones. Peripheral arthritis, such as knee, ankle, or DIP joints, or any of the axial joints, which I just showed. Psoriatic skin disease, inflammatory bowel disease, dactylitis, which is sausage toes or fingers, inflammatory back pain, stiffness or reduced mobility, decreased quality of life, impaired social participation, impaired work or home productivity. All these are common features. It is mostly clinical diagnosis, as I already told you. ESR CRP can be normal in majority, 60% of cases, friends. ESR CRP is normal, and it does not exclude a spondyloarthritis. If it is normal, it doesn't mean they don't have spondyloarthritis. They have spondyloarthritis, but it is mild. Means they may not require a longer treatment, and they might be very active disease responsive or treatment responsive. HLA-B27 positivity, my friends, 90% what you see in textbook is Caucasians, that is whites and foreigners. In Indians, the demographic study, as you know, is very skewed. It is reported around 50% only. We did our own study through radiology in Manipal, actually it's published. And in that, what majority, 1/3 were females actually. And 25% of HLA in psoriasis is HLA-B27, is not very high in psoriasis. MRI evidence is actually seen only in spinal disease. However, you can take MRI if X-ray is normal and you're not seeing visible swelling in feet. MRI is useful, and ultrasound is useful as well to see with power Doppler to see inflammation. X-ray is useful for peripheral joints to see penicillin cup deformity, erosion suggestive of psoriasis, ankylosis in case of spine or bamboo spine, or fused sacroiliac joints, or new bone formation in psoriasis in following joints. Hips, they use for early asymmetrical hip OA or knee OA. All are NSAID responsive. That is a classical pathognomonic or clinching factor of these patients. You use the patient say, sir, ನಾನು one painkiller ತೊಗೊಳ್ತೀನಿ sir, ನಾನು full normal ಆಗ್ಬಿಡ್ತೀನಿ ಅಂತ. That means it is a SPA type of illness. RA don't have that feature. RA is usually steroid responsive, and all SPA are usually classically NSAID responsive. And conventional synthetic DMARDs and targeted synthetic DMARDs are nearly 70% benefit in patients. Methotrexate, sulfasalazine, especially for heel pain and Achilles tendon pain or elbow pain or spinal or axial. Leflunomide, tofacitinib, apremilast, especially for psoriasis. Biological DMARDs in resistant cases, severe cases, young cases, aggressive cases. We use it early, especially anti-TNF. And if it is psoriasis, then anti-IL-6, IL-17 can be used. In IBD patients, avoid IL-17, use anti-TNF, and tofacitinib works as well. So anti-TNF works for all domains such as skin, nails, joints, spine, enthesis, eyes, and IBD. And still the main go-to agent if everything fails in aggressive psoriasis, and anti-IL-17 such as secukinumab or ixekizumab, which works very well for very high skin disease. So we have covered two major diseases, and we are left with 15 minutes. We still have connective tissue diseases to cover and vasculitis. So I will touch upon a few slides on connective tissue diseases and vasculitis. and take a few questions if you have any. In terms of connective tissue diseases, they're collectively called under one umbrella because there are several diseases such as undifferentiated connective tissue disease, systemic lupus erythematosus, Sjogren's, either primary or secondary Sjogren's, mixed connective tissue disease, which is a completely different entity on its own, overlap connective tissue disease, which is different from mixed connective tissue disease, autoimmune myositis such as polymyositis or dermatomyositis, and scleroderma type of disorders. Most of this, almost all of this, are either and, at least ANA-IF or ANA profile. One of these should be there for them to be called as connective tissue diseases. ANA-IF should be done in dilution technique, my friend. There's no point of doing ANA-IF in ELISA method, because in ANA, we need to know certain factors, which I will tell you. We need following things in ANA and dilution technique or end dilution technique. You need to tell your lab that I want an end dilution titer value. That is, starting dilution, they dilute the patient blood and they go on diluting 1:40, 1:80, 1:160. That's called doubling dilution. The more stronger the disease, even if dilution is very high, then you see the antibody, the antinuclear antibody. So that means the disease is very strong or severe or avid. The antibody is very avid. So ANA profile is not a screening test. Don't do ANA profile initially. Do ANA-IF as a screening test. If ANA-IF is positive, you may not need ANA profile unless you want to know whether there is any other subtype of diseases, whether the patient has RNP antibodies, which can cause lung diseases, whether the patient has Rho antibody, which can be useful in preventing congenital heart blocks for patients attempting pregnancy. And you have to do something called as screening for cardiac congenital heart block through neonatal echo or fetal echo. You have to ask them to do. That's why you need this. Otherwise, doing both ANA and ANA profile is not necessary. So ANA profile, I'll do it if ANA-IF is negative. If the antibodies are cytoplasmic, such as if somebody has only Rho antibody positive, or somebody has myositis antibody positive, or overlap disease, PMSEL positive, they may not have ANA-IF, and it may be negative in that, but they are still connective tissue diseases. That's when ANA profile is done. So minimum you need to have is 2+ or 3+ on the strength. Otherwise, just 1+. If clinically very strong, then maybe you may take 1+. But if clinically borderline, 1+ should be ignored. So usually connective tissue diseases are multi-system and they evolve even with treatment. Often my patients start with lupus, with features of lupus and lupus antibodies, and slowly they metamorphose into something called scleroderma. First, we start with lupus, then become scleroderma. That is, they have scleroderma clinical changes. So we call that as overlap connective tissue disease. So you often have to tell patients that treatment is given to reduce the pace of the disease. Treatment is given to prevent the complications of the disease. Suddenly treatment should not be stopped, and treatment cannot be guaranteed that you may not develop further changes. You may or you may not, but your chances of developing the further changes are less if you are on continued treatment. Treatment varied based on symptoms and severity and type of organ involved, which I'll come to. This is a very good picture which actually shows rheumatoid has anti-CCP antibodies, and these are further newer antibodies. And in case of lupus, dsDNA, Smith antibody, anti-ribosomal P antibody, and Sjogren's mostly in terms of SSA and SSB antibody. If a patient has RNP antibodies, then they have usually overlap of rheumatoid, SLE, Sjogren's, and myositis. So that is mixed connective tissue disease. If it's an overlap disease, they usually have one or several of these overlaps. Myositis usually have any of these myositis specific or associated antibodies, that such as tRNA acetyl synthetase antibodies, or anti-SRP or HMG GCR receptor, or TIF1 MDI5, any of these myositis specific antibodies. All these antibodies are associated with a clinical manifestation, which I'll come to very shortly. Now, organ specific treatment. This is important and part of the clinical secrets that usually comes with experience, and hence I thought I will share you with. If your patient has predominant joint involvement, that is, if your patient with connective tissue disease comes and says, "Doctor, I have a lot of pain, stiffness, and visible swelling first thing in the morning," tablets which will work for them are methotrexate, tofacitinib, and tacrolimus. None of the other agents will work. Hydroxychloroquine may work, but not strong enough. So you might have to use one of these or combination of these to get things under control. If it is brain involved, such as in neuropsychiatric lupus, either psychosis or it is cerebritis or cerebral vasculitis or cranial mononeuritis multiplex, then you don't waste time on milder agents. You'll have to use IV cyclophosphamide pulse, 2 weekly 3 pulses, 3 weekly 3 pulses, or monthly 1 pulse. Or you have to use mycophenolate mofetil in combination with tacrolimus or alone. Rituximab, if any of these fail, you can use rituximab early, but rituximab takes 35 to 40 days to work. So cyclophosphamide works the quickest. MMF works in 1 month. Eyes, if patient has uveitis, which I just showed, retinal vasculitis or scleritis, any of these potent agents which you have used for brain, same thing holds good. Serositis, if they have recurrent pleuropericardial effusion or ascites as in SLE, then agents which are very responsive are azathioprine, mycophenolate, tacrolimus, or rituximab. You can use mycophenolate, tacrolimus in combination if severe, starting with singly, then use in combination. If it is milder, azathioprine is okay. Rituximab, of course, if it is severe, may not start working early. If lungs are involved, especially if it is systemic sclerosis or scleroderma, myositis, or mixed connective tissue disease, then standard approved agents as indicated by European Rheumatology Societies are mycophenolate mofetil, which works for interstitial lung disease, rituximab, tacrolimus, tofacitinib, especially for MDA5 lung disease. So mycophenolate can be combined with tacrolimus, especially if your patients have joint involvement. So it works both for lung and joints. I often do that. Failing which you can give rituximab if aggressive, if FEC is falling rapidly, or if it is a progressive refractory lung disease. GI, if it is SLE bowel vasculitis, then aggressive disease, they have to be managed in ICU setting. Cyclophosphamide works very quickly, and mycophenolate, rituximab. Hematological, especially if it is pancytopenia, ITP, idiopathic thrombocytopenic purpura, autoimmune hemolytic anemia, mass like HLH picture, then rituximab works very well. IVIG works instantly for the marrow. Other agents in maintenance are azathioprine, mycophenolate, tacrolimus. For myositis, methotrexate, very useful. Mycophenolate, very useful. Tofacitinib, not bad either. Tacrolimus, useful in combination with mycophenolate, especially if joint disease. Failing which cyclophosphamide and rituximab can be used. Renal, stronger agents such as mycophenolate, renal lupus, any of the class 3, class 4, or class 5, mycophenolate, tacrolimus, cyclophosphamide, or rituximab. If cyclophosphamide cannot be used, you can combine mycophenolate and tacrolimus. Skin, if it is any of the acute or chronic cutaneous lupus or discoid lupus, scleroderma, pepper pot pigmentation or thickening, then myositis, especially if it is a dermatomyositis with cutaneous lesions, azathioprine, mycophenolate, tacrolimus, tofacitinib, cyclophosphamide, rituximab in clinical usage. Peripheral neuropathy due to vasculitis due to Sjogren's works very well with mycophenolate, tacrolimus, cyclophosphamide, and rituximab. Adjunctive treatments, all patients need to be on hydroxychloroquine all patients need to be on hydroxychloroquine unless until contraindicated, such as retinal toxicity. Steroids, if it is moderate connective tissue disease, you may get away with 0.25 to 0.5 milligram per kg tapering dose, and make sure that they reach less than 5 milligram per day by 3 months. Lesser the steroid, better, as told by European Rheumatology Society these days. Chronic steroid toxicities such as cataracts, Cushing syndrome, osteoporosis, diabetes, all the metabolic syndromes are less if it is less than 5 milligram per day. If it is severe, any of the neurocerebral bowel involvement, then of course you need 0.5 to 1 milligram per kilogram per day tapering. APLOF profile is required for CTDs, especially in pregnancy setting or in thrombotic setting. That is, if you ask APLOF profile, they need to have done lupus anticoagulant by mixing method and anti-beta-2 glycoprotein, IgG, IgM, anti-cardiolipin, IgG and IgM. All three should be there. Especially with bad obstetric history, if they're conceiving, please do it. And they have to be anticoagulated and antiplatelet should be given. High lubricants and salivary stimulants, as I already told you. So certain disease-specific attributes. Low C3, anti-SM, anti-dsDNA are very suggestive of, if done by ELISA, of lupus. Even if it's an overlap disease, it shows that lupus is dominant. Anti-RNP antibodies actually predicts lung involvement, and 99% of MCTD patients have RNP. You can't make an MCTD diagnosis without RNP diagnosis, the antibodies positive. Has to be there. And ILD involvement, anti-RNP usually causes ILD involvement. So such patients, it's not harmful to get 3 monthly or 6 monthly PFT rather than directly get a CT scan. And PFT is dropping, you can get a CT scan. RNA polymerase 3, especially in scleroderma, you found has kidney involvement with renal crisis involvement, which I have not touched upon, and causes high blood pressure suddenly if steroid use more than 15 milligram per day. Has to be managed with A2RBs and blood pressure control. Rashes on eyelids, necklace areas, and back of neck, called as shawl sign, V sign, is more indicative of dermatomyositis, especially cutaneous dermatomyositis. Biopsy is very much required to prove this. Pepper pot pigmentation on the back and the neck, white and black dots, especially seen in scleroderma disorders. Malar photosensitivity rash, more of SLE. Microstomia and perioral thickening, more of scleroderma. Anti-MD5 antibodies, if found, these patients usually develop ILD with myositis. So, it's usually you have to ask for myositis profile in the lab. Anti-TIF1 gamma, if found in myositis profile, screen for malignancy with PET scan. All myositis you may not need this, especially and dermatomyositis patients. PET scan is usually preferred. If not available, CT chest, abdomen, pelvis. Anti-ribosomal P, more of neurological development, can be used as a biomarker actually. Digital pits and Raynaud's more indicative of scleroderma type of disorders. So what a clinician needs from ANA report, you need a starting dilution point, which is 1 in 100 is a good starting point. Anything below that, a lot of false positive will be there. And you need to have serial dilution. Stronger the disease, higher the dilution titer. Anything above 1 in 160 is significant if clinical features are there. And strength 2+ or 3+ if clinically significant and above. Pattern, very helpful. Speckled, more of SLE type of disorders. Nucleolar or centromere, more of scleroderma type of disorders. Now, coming to vasculitis. So that's the last talk of mine today. So vasculitis based on whether you have large vessel, that is aorta and its branches, giant cell arteritis or Takaiso arteritis or cranial arteritis, medium vessel, which is polyarteritis nodosa, which is non-granulomatous, or Kawasaki in kids, coronary arteritis, and small vessel with ANCA, which is Wegener's, which is a granulomatous, and microscopic polyangiitis, which is called MPA, and Wegener's, which is called GPA these days. MPA or microscopic polyangiitis is non-granulomatous. Small vessel with immune complexes, ANCA positive to some extent, and granulomatous or Church-Strock, which is called EGPA, that is eosinophilic granulomatous polyangiitis, and non-granulomatous or cryoglomerular vasculitis and Behcet syndrome. So varied symptoms, my friends, pattern depends on the size of involvement. Imaging is mandatory for large vessel vasculitis and medium vessel. Biopsy is necessary for medium to small vessel vasculitis, skin or nerve or kidney or lung if possible. And life-threatening if any of brain, heart, lungs, or intestines or kidneys are involved, then you have to act quickly to prevent life-threatening manifestations. Always rule out infections and malignancy as a mimicker, especially if all antibodies are positive or none of them are positive. So if all or none is there, then you have to think whether you're dealing with something else. So predominantly large vessel are Takayasu, and predominantly medium vessel, as I told you, is polyarteritis nodosa, which can be either systemic or cutaneous, and GPR granulomatous, which is Wegener's and or EGPA, and non-granulomatous small vessels, as I just told you, Enox-Conlin, MPA, then IgA vasculitis, hypocomplementaric urticarial vasculitis. Other vasculitis disorders are Behçet's disease, hypersensitivity vasculitis, ENT involvement of Cogan syndrome. So generally, if some patients present with stroke kind of involvement in young, cerebral vasculitis or primary CNS vasculitis can be thought of. If ischemic heart disease in the without the context of or cerebral, myocardial infarction with coronary arterial involvement, extreme hypertension, refractory, and epistaxis or nosebleed, frequent scleritis or panuveitis, and ischemic bowel involvement, pain after eating or bloody stools, with if patients have hemoptysis, systemically unwell, rapidly progressive shortness of breath, and you see a lot of DH kind of picture, alveolar hemorrhage, and rapidly progressing glomerulonephritis, with arthritis as well, which are polyarticular, palpable skin purpura, libido, fever, weight loss, loss of appetite. Many varied manifestations are there in vasculitis. These patients have to be thoroughly looked at in history and examination, and immediate treatment have to be started, waiting for investigations. I realize I've just crossed the time, but just few last slides finishing off. Investigations, you check for inflammatory markers, majority have high ESR CRP. You have to look for there's rapidly falling hemoglobin or cytopenias. Immunoglobulins, you have to check. Complements, if it's complement consumption and falling albumin, and systemic involvement with deranged liver functions, renal functions, proteinuria, hematuria, muscle involvement with pulmonary functions test, PFTs and GLCO, and laryngoscopy may be required if ENT involvement for biopsy, GI involvement, colonoscopy or endoscopy, and eye involvement for ophthalmology for relevant findings, and neurological, of course, with neurology involvement with suggested MRI scans. Autoimmune antibodies, you need to screen out other connective tissue diseases, so ANA, rheumatoid factor, and ANCA positivity, of course. ANCA positivity may not be there in all patients. So usually, some patients are ANCA negative, only 30% of them are ANCA positive. So a negative ANCA may not rule out. Such cases, biopsy is mandatory. Skin, muscle, nerve, renal, lung, any of these are the crucial areas. Whichever amenable, please take it before you subject them to long-term heavy immunosuppression. Always rule out infections, especially the chronic infections, including HIV, and for cardiac tests, relevant ECG echo and EMG nerve conduction tests if neurological involvement is there, and chest involvement, CT scan and MR brain, either plain or with diffusion images if you have to look at ischemia, or angiography if you have to look at large vessels, such as CT iotogram if you are looking at large vessel vasculitis. PET-CT is useful for new diagnosis of large vessel vasculitis. For monitoring its heavy radiation, MR angiogram is preferred. And PET-CT is always useful for ruling out other occult infections and malignancies. Because terms of treatment, majority of the Severe vasculitis need induction with prednisolone 1 milligram per kilogram tapering and aiming for 5 milligram to 10 milligram by 3 to 4 months. And milder cases, you can use methotrexate, but severe ones need mycophenolate for Takaysu arthritis. Other agents of use which are steroid sparing are anti-IL-6, such as tocilizumab and infliximab, especially if it is resistant. Giant cell arthritis, usually if seen in especially non-cranial, if seen above 50 years with rapid weight loss, fever, systemic signs, nothing is proven in infections, and a PET CT shows iotitis. Such patients has to be treated as large vessel vasculitis with tapering dose of steroids and with maintenance of methotrexate or leflunomide either in combination or alone. And IL-6 and anti-TNF can be used early for better quality of life. Polyarthritis nodosa, which is usually the erosional disease. These days, Dada syndrome, which is the genetic counterpart of it, if family history is there, and a lot of these patients need tapering dose of steroids starting with 1 milligram per kilogram, cyclophosphamide, rituximab, but induction, either one of them, with maintenance of azathioprine, mycophenolate, or tofacitinib. Cutaneous pan, myself have published 5 cases now of excellent response with methotrexate and tofa. Granulomatous polyangiitis or Wegener's with induction, now it is proven in many of the trials that rituximab induction and maintenance is better, superior to cyclophosphamide in terms of preventing relapses. So as Azuran is better for maintenance compared to mycophenolate. But either or is inadequate response, you can switch over from cyclophosphamide to rituximab. Microscopic polyangiitis, same way as GPA, absolutely no difference. Only clue is if renal disease is aggressive and early, then I suppose, if such patients, I would probably think that if they have asthma as a childhood history and renal disease is early and severe, I would probably think of MPA as a possibility than GPA. So if cavitating lung lesions, ENT lesions, and renal, I would think of GPA. These are the pathognomonic pattern recognition between GPA and MPA. Whereas an aneurysmal disease, an odd area of involvement, such as testes, parotids, or any of those, then of course you can think of PAN as a picture. IgA vasculitis, kidney involvement, Henox-Conlin type involvement, 0.5 milligram per kilogram is enough. Some of these have neuropathies involved also, but your standard treatment such as methotrexate, azathioprine, mycophenolate, tofa is more than enough. Behçet's with eye involvement or any of the cutaneous involvement, or even to some extent thrombotic involvement, you need immunosuppression with these cases, where in thrombosis, anticoagulation in Behçet's is contraindicated, and you give immunosuppression for thrombosis, such as with steroids tapering dose, followed by azathioprine, cyclosporin, mycophenolate, anti-TNF such as infliximab if resistant, apremilast especially for recurrent orogenital ulcers, very good trials, studies in trials, and colchicine as well. So the summary is history and physical examination is very important. Focus test based on history and examination. Initiate treatment early to mitigate problems and damages. Appropriate diet such as low saturated fat diet, low carbohydrate diet, sugar, sweets, rice and potato less in quantity, paneer, cheese, ghee less in quantity, mutton, beef and pork completely avoid, and no packeted or processed food. Always ensure make them see their physio. Stretching exercises mandatory all their life so that they keep their joints supple, and stretching and strengthening exercises to improve their muscle fitness, and cardio exercises such as brisk walking, jogging or running to improve their stamina, energy levels and self-immunity and confidence. It's important that at the end of the day, disease is not the be all and end all, my friends. You have to tell patients that disease may be lifelong, but treatment is not. Once you have achieved treatment with slow taper, we may be able to try and stop the treatment. If not successful, at least maintain on a small dose, provided you're maintaining proper diet and you're physically active. So we ourselves did a study where sitting more than 6 hours without break and no exercises did bad in all our arthritis patients with the same treatment compared to those who regularly exercised and take frequent breaks while sitting. And in fact, we published that in European Journal of Rheumatology, such as Annals of Rheumatic Diseases and Abstract in the last concluded June conference. So confidence, positive mental strength, and belief in self and belief in treatment, belief in doctor. You should tell them that believe in what I give you. You will be better. Believe in yourself so that they stop roaming around and asking for help. Unless you instill that confidence, patients will not be able to handle themselves. And if you leave them in hopeless situation, telling that whole life is point, then they will not be able to cope up with that, my friend. So with that, I actually thank Aventus for bringing this idea. This Zoom platform is mine. They've got nothing to do with this, but they were the one who actually said, why don't you engage doctors in teaching how you practice and how you talk to patients, how you teach your staff. So I use this platform to teach my staff who are also logged in and teach my doctors who are kindly referring to me and students as well. So I thank my team. I thank my patients who have given me this wisdom. They are my teachers. I thank my parents who have brought me to this world. I thank God Almighty to given me this wisdom and given me this life. With that, I'm 10-15 minutes overboard and I end my talk. And now I shall see whether I have any questions to share from in terms of chats. So I see that probably there's nothing much to talk about in terms of questions. So I thank you all. You can approach me individually by messaging me. Then I shall take you any questions or separately email me, or contact numbers in my slides are there. You can post your questions there. Thank you very much. Have a beautiful Sunday.